Hello everyone, welcome to another episode on the House Officer series. Today, we will be learning how to overlap insulin. Overlapping insulin is commonly done in wards. It essentially means transitioning from continuous intravenous insulin infusion to subcutaneous insulin. We will be providing you with a general approach to overlap insulin. First, we will learn why are the patients on insulin infusion. Who are the patients that usually require insulin infusion? When to switch intravenous to subcutaneous insulin. What are the types of insulin we can choose to overlap? How are we going to overlap insulin? Intravenous insulin are given continuously using an infusion pump. It maintains blood glucose levels safely below the upper limit of their respective target ranges without substantial risk of hypoglycemia. Usually diabetic patients that are kept nil by mouth will be started on insulin infusion. Other patients that may need insulin infusion are perioperative patients, critically ill patients, patients that suffer from acute myocardial infarction or acute stroke. Those patients in diabetic ketoacidosis or hyperglycemia hyperosmolar state, or sometimes during labor and delivery, may need insulin infusion too. We can consider switching intravenous insulin to subcutaneous insulin when patients become stable after a critical illness or an acute event like myocardial infarction or stroke. We also can switch when good oral intake is established and patients are taking regular meals, no matter whether it is after the operation, DKA or HHS resolved, or post-delivery. Most of the time, intravenous insulin infusion is switched to subcutaneous premixed insulin, or basal bolus insulin. However, if the patient's diabetes has been well controlled, we can consider to overlap with oral hypoglycemic agents instead. When converting from intravenous insulin to subcutaneous insulin, first, estimate the total daily dose required based on the insulin infusion in the last 12 to 24 hours. Alternatively, we can also estimate using patient's body weight. Consider to reduce 10 to 20% of estimated total daily dose if patient's oral intake is still not good or patient was previously on dextrose drip. Elderly patients or those who are at high risk of developing hypoglycemia should have their total daily dose discounted too. Next, determine the types of insulin regime based on your patient profile. If premixed insulin is preferred, divide the total daily dose into 60% pre-breakfast and 40% per dinner. If basal bolus regime is chosen, divide the total daily dose into 20% pre-breakfast, 20% pre-lunch, 20% pre-dinner and 40% per bed. Use short-acting insulin for pre-meal boluses and intermediate-acting insulin for pre-bed. Once regime has been determined, you may discontinue the insulin infusion half an hour after subcutaneous short-acting insulin has been administered. These pie charts summarize the percentage of total daily dose when converting to subcutaneous basal bolus or premixed insulin regime. Pause the video and carefully read through. I hope it will help you during your ward round. Please give us a thumbs up and click on the subscribe button if you find the content useful. See you next week.